day for appropriations today, so I just want everybody to get comfortable and get engaged in some of the things that we're doing. My co-chair and I have talked about nursing homes and the Medicaid reimbursement, so we decided to ask the experts to come and explain the good and the bad of this process so that we can talk about funding. And then we also, hopefully, during the deliberation, we talk about some of the other things like oversight and some of the issues that we think need to be addressed for our nursing homes. So with that, I'm going to see, is my co-chair able to say good morning?
Good morning, everybody. I'm hoping that we can move this along. Looking forward to
Okay, great. Thank you. Let's see. Senator Berthel, are you on call? Okay, maybe not. Representative Nuccio, are you on?
I am, ma'am.
There you
Thank
go.
you very much.
Good morning.
Good morning to you too. I just wanted to say, I'm looking forward to this. Being cross-referenced over on insurance, we hear a lot about nursing homes and long-term care and that. So I'm really interested to see the intersection here. And thank you very much for putting this together for us.
Thank you. Thank you all. So with that, I'm going to ask, let's see, who's first on the docket? I believe it's Meg.
Thank you, Representative Walker.
Mm-hmm.
And good morning to everyone on the committee. Senator Austin, Representative Walker. Pleased to introduce myself. I'm Mag Morelli, the president of Leading Age Connecticut. Leading Age Connecticut is a membership association representing not-for-profit and mission-driven providers of long-term services, supports, and housing. And our membership includes 39 such nursing homes. I'm joined by my colleague, Matt Barrett, and we're both very pleased to have been invited by the committee's leadership to provide a broad overview of the nursing home Medicaid reimbursement system. We've put together several slides of information we thought would be helpful, utilizing data and information drawn directly from the state and federal resources. In fact, you'll see we've borrowed a few of the terrific graphics used by our state Medicaid director, Guy Woolston, when he presented recently to MAPOC, but we did credit him for those slides. We've tried very hard to make this an educational presentation that will be of benefit to the membership of these committees. And we have left plenty of time for questions at the end, but we will defer to the chairs as to when you'd like to entertain questions. We've also put in a few slides outside of the reimbursement system just to provide a broader context for the discussion. So
just Meg, I just want to say what we'll do is we'll listen to your presentation and Matt's, and then we'll have questions, okay? So that everybody knows that. Okay, great.
Perfect.
Go
All
right.
right. Thank you. And with that, I'd like to introduce Matt Barrett, and he will begin the presentation. Matt?
Thank you, Mag, and good morning to the leadership of the Appropriation and Human Services Committee. My name is Matt Barrett, and I'm the President and Chief Executive Officer of the Connecticut Association of Healthcare Facilities and the Connecticut Center of Assisted Living, a long-term care trade association that includes 151 skilled nursing facilities all across Connecticut. And I'll begin with the overview of the presentation, beginning with there are 205 licensed skilled nursing facilities in Connecticut, 10 of which do not take Medicaid, and 40 of which are nonprofit skilled nursing facilities. The licensed bed capacity in the sector is 24,295 beds, and the homes range in size from 25 bed facilities to as much as a 360 bed facility in Connecticut. The statewide nursing home census in Connecticut as of December 2022 was 83.67. We consider that almost 84% occupancy. Pre-pandemic, our occupancy was closer to 88% at 87.6% occupancy. Between 1995 and 2022, 82 nursing homes have closed. That amounts to 7,858 beds that were removed from the licensed capacity of the overall sector. And one was converted from a chronic disease hospital to a skilled nursing facility that was 125 beds. Operating homes have reduced their capacity by as much as 438 beds just in the last 2 years. And there are approximately, we estimate, 30,000 people that comprise the workforce of Connecticut skilled nursing facilities. And Connecticut skilled nursing facilities are part of a continuum of long-term care supports and services that is comprised of home and community-based services such as homemaker, companion, personal care, adult day services, Meals on Wheels, and so forth. Also residential care homes, assisted living communities, continuing care retirement communities, home health care agencies, hospice agencies, and again, skilled nursing facilities. And there are 205, as I previously mentioned. Very briefly, in terms of the payment system, who pays for this care? Medicaid is the source of payment for 72% of nursing home residents. The average Medicaid per diem rate, including the client share, which we often refer to as the applied income, is $280 per day. 50% of that rate is paid for by the federal government, often referred to as the federal match or federal financial participation. And this is, of course, I'm referencing a number that is unrelated to the public health emergency, but there was an additional 6.2% match rate during the public health emergency. And the nursing homes pay back the state a $21.02 per day nursing home user fee, and we often hear referred to that as the nursing home provider tax. Private pay accounts for a small portion of the payment source. It's about 9%. And the average private pay rate in 2021 was $462 for a semi-private room due to the need to shift the cost to this source. Medicaid only pays for short-term post-acute rehabilitation stays. Medicaid Advantage on average pays lower than traditional Medicare. And continuing with the nursing home overview, the federal government has no system of paying for long-term care, the long stay that we're referring to that is paid for by Medicaid, other than the Medicaid program. Historically, nursing home care was one of the only long-term care services covered under the Medicaid program, but now many other options have been added to the long-term care services and support system in the area of home and community-based care, including the Connecticut Home Care Program for elderly, and which we often refer to as the Elderly Medicaid Waiver Program. Today, many residents arrive at the nursing home with limited private funds, who've spent their resources down in other environments, principally assisted living communities or in their own homes, or and less often in the skilled nursing facility itself. And then they quickly qualified for Medicaid, and this explains why some 72% of nursing home residents in Connecticut are Medicaid recipients. And with that as the pause, I'll return it back to Mag Morelli, who will complete the slide deck.
Thank you, Matt. Yes, we have a few more slides until we get into the rate system. How do you qualify for Medicaid coverage for a nursing home stay? Federal rules dictate that eligibility process for long-term services and supports. A nursing home resident must spend down to just $1,600 in assets to qualify for Medicaid to pay for their long-term care nursing home stay. The state takes a 5-year look back on their finances and penalizes an applicant for any inappropriate transfer of assets that occurred during that 5-year look back. It's a DSS qualification. It is not the IRS gift rules, but it is the DSS CMS gift rules, and it is full 5-year look back. The application for a long-term care Medicaid, or it's referred to as Husky C, is very long and detailed, although there have been efforts in recent years for DSS to make it a more efficient system for the applicant. There are protections in place to maintain a portion of the financial assets for the community spouse. And nursing homes residents' eligibility is redetermined every year. Even though they do have to spend down to $1,600 in assets, they still have to be redetermined for Medicaid each year. So the state's Medicaid spend on long-term services and supports is very large. In fiscal year 22, the long-term care Medicaid expenditure was $3.5 billion. That's state and federal funds together. 42% of that spend was on institutional care. 58% of that spend was on home and community-based services for people who are remaining in their homes or in the community, receiving services and supports that are Medicaid funded. 69% of Connecticut's Medicaid long-term care clients are home and community-based service recipients. This is really tremendous. I mean, if you look back, and we put this note in just for context for you, 20 years ago, 31% of the spend, just 31% of the spend was on home and community-based services, and only 46% of the recipients were served in the community. So Connecticut's come a long way in our rebalancing, that you may hear that term rebalancing the way we distribute our funding and provide our services for long-term services and supports between an institutional setting and the home and community-based setting. This is an important factor, I think, that people need to understand, and often it's forgotten because it happened in 1991. But in 1991, the state legislature put a moratorium on building new nursing homes. No new nursing home has been able to be built outside of a few exceptions since that time. A rigorous certificate of need process was put into place to regulate renovations, replacements, or investments into existing buildings, nursing home buildings. The CON process for nursing homes is overseen by the Department of Social Services and is completely separate from the hospital CON process that occurs over at the Office of Healthcare Strategy. So you see some of our right sizing efforts, bed location, building conditions have all been impacted by this moratorium that has been in place for 30 years. So now we get to how nursing home Medicaid rates are determined by DSS. Connecticut uses a cost-based method to calculate the per diem nursing home rates. Each nursing home has their own per diem rate calculated, their unique rate. And it's basically, and to do this, to do the cost-based methodology, nursing homes must submit a cost report each year to DSS. The state uses these cost reports during a rebase year, and we'll explain to you what a rebase year is in a minute, to calculate the per diem Medicaid rate for each individual home. Cost reports are categorized into 5 cost buckets. There's the direct bucket, the indirect costs, care rent, capital, and then the administrative and general bucket. The state only recognizes the allowable costs in each of these buckets, and they cap the costs in the rates, they cap the costs in the direct, indirect, and administrative buckets before they calculate the rate. So there are controls on the cost that they use to calculate your rate. This is another one of the graphics that our Medicaid director used in his presentation, and it just gives you a visual. The nursing homes incur the costs, you submit your cost report to DSS annually, then DSS sort of cleans up the cost report, takes only the allowable costs and caps some of the buckets, and then they calculate your rate using the formula as dictated by statute and regulation. This is a little fuzzy because I took this directly from Guy Woolston's presentation, but it gives you a sense of what's in each of the categories, what's not allowed as costs, and then it gives you a sense. I'm just going to move my gallery here so I can see this a little bit better, but how it breaks down, the allowable cost breakdown. So in your direct category, which is this purple section, and that's 51% of the allowable costs, that's your direct: nurses, nurses' aides, salaries, your nursing pool costs, that's all in the direct category. Indirect are your recreation, social workers, dietary, housekeeping, laundry, and the supplies that are related to patient care. So that's all also related to the care that's provided. That's the light purple, that's your indirect costs. Administrative in general, that's your maintenance, plant operation expenses, salaries and fringe benefits for your administrative staff, your maintenance personnel. It's also things like your insurance, and I mean your utilities, your water, your heat, your generator, all of that goes into administrative in general. Property, that's your building, your property, your mortgage, and capital related expenses are your taxes. That's where your insurance goes, your movable equipment, you're buying new beds, whatever it is, your new Hoya lifts, and then the depreciation on that equipment. Here's a list of what's unallowed in your costs, and then you can see the breakdown right here in this pie chart. So now we have a change in how we're calculating our nursing home rates. In 2019, Connecticut redesigned the cost-based reimbursement to add to it a quarterly adjustment to that rate to recognize the acuity level of residents. It's really a modernization of our rates. This was not implemented right away because of the pandemic. It was delayed until July of last year when we started to phase in this new acuity adjusted rate system with a planned 3-year phase in of the new rates. The new acuity system is going to adjust the payments made to the nursing home based on health needs and expected costs of Medicaid residents living in the nursing home at that time, and using the resident data currently collected by nursing homes and submitted to both the state and federal government. It's called the minimum data set, the MDS. This is something nursing homes have been doing for years. It's how you're paid for paid on the Medicare system. And so now they're using that same system, or they're adjusting it at Medicare. And that's just sort of a topic for another day. But they've been submitting it. It's all of the information on the resident that helps the federal government and now the state government calculate the acuity needs of your residents. Now, the cost reports are still going to be used to calculate the base rates in this new acuity adjusted system, because some of your costs are going to remain the same no matter how the acuity level is of your residents. So your food, your utilities, your housekeeping, your administration is all going to remain the same, but the real variable here will be your direct care, and in some sense, the indirect care. That's the most highly adjusted cost variable within the acuity adjusted system. And quite frankly, one of probably the most expensive category of costs for a nursing home. This was Guy's graphic of that, showing that, you collect the MDS data. That MDS data will be scored and calculated into a case mix index. They'll calculate the payments on a quarterly basis, and on a quarterly basis, your rates will be adjusted depending on the acuity measure of your residents in the building. As I said, we're modernizing our system because acuity adjusted systems are used in most other states. It incentivizes nursing homes to serve the highest needs residents. So now you know that if you bring in residents that have higher needs, your rate will adjust so that you'll have the resources to pay for them. Ensures that Medicaid dollars are flowing to homes based on the level of resident need. And there's also a recognition that very high levels of care, such as ventilator care, can also be addressed through such a system. And actually there will be special rates developed for homes that develop ventilator units, bariatric units, because these are really in high need. We're currently working on this issue of the 2 associations with the hospitals and with DSS, because we're really seeking a better and more appropriate discharge from the hospital to a appropriate level of care and setting. And so we need to develop these special care units within the nursing home. And then even if it's for short term, as residents with these special needs potentially can be transitioned to another lower level of care. So as I said, we're phasing in this new modernized system. The base rates for the new acuity system were rebased using the 2019 audited cost reports, and DSS asked for a 3-year phase-in of these rates. This rebasing is a very, very big deal, and we are so appreciative that the legislature and the administration worked to allow us to do this. It had been years since nursing homes were actually paid on their rebased rates. Every 2 to 4 years, the state was required to rebase your rates. So do the actual calculation, take your cost report, audit the cost report for the rebase year, calculate what your rate should be based on the formulas. They would tell you what that rate should be, but then due to fiscal constraints, the rates would either be just a 1%, 2%, or a freeze on the rates. And so what happened is the rate system got very out of whack, and many, many nursing homes were receiving a rate much lower than the actual calculated cost and what they were actually spending to serve the Medicaid resident. This rebase of the 2019 cost reports was going to cost the state $90 million. And so the DSS said, can we phase this in over 3 years so we have some sense of a better budgetary sense of how we will phase in this new expense. And so that was done. So this year, when it went into effect in July, there was a $6.50 stop gain. So anyone who had a large, and there are some people that have a significant increase in their rate, but it was stopped, it was capped at $6.50. This July, the next increase will be put into place. It's a $20 stop gain, but that's really $13.50 more than the increase they got this in July of last year. And then it'll go into full effect in 2025. Now, some homes will actually also lose in their rate. because their new rebased rate showed that their costs were a little bit lower than than what their calculated rate will be. So some homes will go up and some will go down in this 3-year period. Just of note, not only were we rebased last year, we also received a 4.5 rate increase in each year of the biennial budget that was to go specifically to staff wages and salaries. Now that is the acuity rate system, the 3-year phase in, and we were actually pleased to see that the governor is proposing to fund that in the next 2 years as planned when we put it into place last year. There's also a quality payment measure in this system, and that's expected to go into effect this July. Nursing homes will have an opportunity to earn a quality payment based on achieving certain predetermined quality measures. Nursing homes have a lot of quality measures that they're judged on and reported, and that they report, and those quality measures are currently reported through the CMS Care Compare website. So the Department of Social Services is attempting to work with that current system to find certain quality measures, to choose certain quality measures to use within this quality payment system. It's being done with great intention to achieve specific quality outcomes, and it's expected to change over time. So in this next year or two, we may choose a quality measure that we see Connecticut providers falling behind the rest of the country. We say we really need to do better in this quality measure. So that'll be the measure we pick. That will be the incentive for people to get an additional payment. You do better on this quality measure, say it's a pressure ulcer, maybe it's has to do with antipsychotic medication prescriptions, whatever it might be. And I'm choosing some of the quality measures that maybe people are aware of that Medicare has looked at. And then as we change behavior over time, because we've made this an incentive, we may see that there are other quality measures that we want people to pay attention, to really invest in and really move the needle on, and then we'll change what quality measures will be attached to this quality payment system. Now, nursing homes are not the only provider that will have a value-based payment system. In fact, we're probably one of the last to come into this system. Physicians have this, hospitals have it, others have it in the Medicare system. Home and community-based services in the Medicaid system are now being paid a value-based payment for certain quality measures. And so we're very pleased to be working right now with DSS on developing the system. It's been a very collaborative process. We've really been trying to work together to implement something that is very meaningful and that will really help to improve the quality of care in nursing homes throughout the state. We wanted to put in a slide to talk a little bit about how the Medicaid payments and cost reports are audited. There are periodic audits of the cost reports conducted by DSS. When the cost reports are submitted annually by the nursing homes, a profit and loss statement of related parties that receive over $50,000 from the nursing home must be submitted to DSS with the cost report, as well as other schedules and information that is required in the cost report. There have been specific audits of the rate increases intended for wages that the legislature granted to the nursing homes. They're currently being conducted. They are almost completed. Last year, the legislature also passed a law that would allow DSS to assess civil penalties on nursing homes that receive a rate increase to enhance employee wages. Matt and I check in with DSS periodically to see how people are doing on this. The last report we got was that people are doing very well. DSS is on top of this, making sure that people are utilizing these funds as required. And they follow up on any complaints or concerns. Sometimes there's just a misunderstanding of what the increase was amongst the employees. And DSS works very hard to make people understand this and is very diligent on investigating any reported misuse of the funds. DSS is now auditing the MDS data. Federally, the Medicare CMS audits the MDS data currently because it's used for Medicare payments, and now DSS is auditing the MDS data because it's being used to measure the acuity. And all cost reports and rate letters are posted on the DSS website. There's a lot of information on the DSS website. Later on in the presentation, I give you a slide of all of these links to various public websites that you can get this information. But DSS does a very good job in posting lots of things on their website that are helpful, that are public information and helpful to understand the reimbursement system. Just a couple slides on the regulatory oversight, which is not done at DSS, but is done over at the Department of Public Health. So nursing home quality standards are regulated on both the state and the federal level, and we're one of the most highly regulated entities in the state. First, we're licensed by the Department of Public Health, and we're regulated from the state perspective from the Public Health Code regulations and state statute. We're also regulated by the U.S. Centers for Medicare and Medicaid Services, or CMS, and they have extensive regulations for nursing homes on the federal level who participate in Medicare. All Connecticut nursing homes participate in Medicare. And there is actually a law in Connecticut that if you participate in Medicaid, you must participate in Medicare. DPH enforces both the state and the federal regulations. So they enforce the state laws, but they're also contracted with the federal government to enforce the federal regulations. And they do this through an annual unannounced inspection process and through complaint investigations. Nursing home violations that DPH finds result in a range of penalties, including deficiencies, citations, civil monetary penalties, restrictions on admissions, and even closure, depending on the severity of the penalties. When a nursing home is surveyed, this is just so you know, when the survey process that is designed by the Centers for Medicare and Medicare Services, when they come in, they do not look for what you are doing right. They only look for what you're doing wrong. So you don't get points for things that you're doing right. You only get deficiencies or citations for what they find in error. And I say that so that you know when you look at a report, you know that you understand what you're looking at and what the inspectors are instructed to look for. Violations, any violation must be corrected by the nursing home within a prescribed timeline in order to come back into compliance and continue to be certified to serve Medicare and Medicaid patients, residents. DPH also oversees changes in ownership, changes in licensure, for instance, if you want to reduce your bed size, and they also regulate closures. DPH oversees and inspects physical plant operations. That's a big job for them. They oversee if there's a CON approved renovation or construction project, DPH oversees the actual construction. Once you get your CON from DSS, DPH takes over and makes sure that you implement it correctly and that the residents are protected during any type of renovation or construction project. DPH is also a partner in our long-term care mutual aid plan. And I mention that because this is a best practice, and we are, it's our mutual aid plan amongst the long-term care providers is looked at from across the country as a best practice. Just an example of what we do in this very sophisticated plan where we are equipped to at any moment be able to receive residents from an evacuated nursing home or to assist a nursing home that is in trouble from a physical plant perspective, a flood, a hurricane, a fire. Back when Hurricane Sandy was hitting and the New Jersey and New York nursing homes were in crisis and needed to evacuate residents, and they were scrambling to find beds. When they called Connecticut, within a number of like 2 to 3 hours, we were able to respond with not just, yes, we can take residents, but exactly where we could take them, where our open beds were, how many ambulances we could send, and be able to accommodate probably most of who they needed to evacuate. They did not take us up on it, but it just showed the difference between a state that had a very sophisticated long-term care mutual aid plan and states that did not have any type of plan put into place. So we're very proud of that plan that we have. And then I'm just noting here, as we're talking about oversight and we're talking about all the different factors that oversee a nursing home, the Long-Term Care Ombudsman Office is an independent entity. They're not part of DPH and they're not part of DSS, and they serve as an advocate for the nursing home resident. That is their role. They're working for the nursing home resident. And so I just wanted to make sure we delineated them and made you understand where they stand in this sort of triumph of DSS, DPH, and then the Ombudsman. Nursing home staffing. Last legislative session, the state legislature directed DPH to implement a 3.0 minimum direct staffing level for nursing homes. The federal staffing requirement is that you must staff at a level sufficient to meet nursing needs of your residents. And DPH also enforces that standard. Now, CMS is in the process of studying and developing the implementation of a more specific staffing ratio on the federal level, with the possibility of issuing a rule as early as May of this year. And you may have heard of that. The Biden administration really instructed CMS to do this. And so we are waiting. They've studied it and we're waiting for them to come out with a ruling shortly. Unfortunately, all of this work and attention at staffing is happening at a time when we're having a severe workforce crisis. On a national level, nursing homes experienced the worst job loss within the larger healthcare sector during the pandemic. And as we've discussed with the former commissioner of DSS and DPH, we are the slowest at recovering from that job loss, the nursing home sector. And for the nursing home sector, it's not just impacting the direct care, but also the indirect care, our housekeeping, maintenance, dining, social work, rec therapy, administrative services, leadership. I mean, one thing we learned during the pandemic, that leadership in this sector is so critical in running an efficient, effective, and quality nursing home. And we're just, through retirement and job loss, we're losing people, and we need to build that pool that we can hire from, and that the entire healthcare sector can hire from so that we can really bring our workforce back to the level that it needs to be at. I mean, right now, many nursing homes are limiting admissions from the hospital due to staffing shortages because they just won't take an admission if it's going to reduce their staffing standard. Many are utilizing costly temporary nursing agencies because they just can't find people to fill the staffing positions that are open right now. So we just wanted to end this portion of the presentation by saying that, CHCFC, CAL, and Leading Age Connecticut are ready to collaborate with the state legislature and the administration. On behalf of our members, we look forward to the dialogue and the discussion to ensure quality nursing home care in Connecticut. Now, this presentation, which we will share and have shared with the committees, includes links to the publicly available information, the DSS nursing home reimbursement website that I was talking about that has the cost reports, the rates, the census, the rate system methodology, history of all of the rate system are all on the website. CMS Care Compare, that's a link directly to the nursing home section of that site that has the 5-star rating for nursing homes, inspection results, staffing information, ownership information, vaccination data, quality measures, all are on that CMS Care Compare. Other resources, we provide some links to some of the most recent reports on nursing homes produced by the state's various agencies and departments. And then we just gave you a slide of the acronyms because we know we all talk a lot in acronyms. We apologize. We know sometimes it's hard to understand the acronyms. So we thought that might be helpful to you also. So thank you for this opportunity to present that overview. We hope it was helpful. We hope we didn't go through it too quickly. We're happy to answer any questions. Susan, would you like me to stop sharing now as we go to the discussion portion?
You might want to keep it up just in case
Okay.
people have questions directly related to your slide. Before we get into the question answer, I apologize. I did not see the chairs of Human Services, Senator Lesser and Representative Gilchrist on, and I welcome them to this hearing today. So if you have a question, please raise your hand, and I'm going to ask everybody to start with 2 questions in the beginning, and then we come back so that we can get some of those questions answered. And I'm going to go first to my co-chair, Senator Austin.
Thank you very much, Madam Chair. I appreciate this very much. Now, my understanding is that there has been recently some nursing homes who have received attention that have been in the local papers, depending on where you live, relative to immediacy of resolving whatever the issues are. When somebody is saying that they're not getting, when a nursing home is saying to DPH that they are not getting the nursing staff that they need or the administrative or maintenance staff that they need, and it results in them not being able to accomplish the mission of a nursing home. What is the end result of that, if they get a citation after repeated asks for help relative to staffing? Do you have an idea? Either Meg or Matt?
I can begin. I'm not sure the request for additional staffing or resources is directly related. Perhaps I might say it might be unrelated to what we view as DPH's regulatory oversight responsibilities. Requests for resources would generally go to the payment agency, the Connecticut Department of Public Health. Strike that, the Connecticut Department of Social Services. And there are some mechanisms for getting additional rate relief, although they're very challenging and difficult to achieve. Sometimes referred to as the interim rate process or hardship rate relief process. And that's to, gain additional help for cost increases or inflationary increases that weren't considered. They weren't considered because they weren't known when the base rate was established, and there isn't a rebasing schedule for several years. So there is a process, but I do have to say that I'm not aware of a single nursing facility that has achieved a hardship rate relief under that process, even though some number of nursing homes, especially during this period of high inflation and increased staffing related costs and increased pool costs, have requested interim rate relief. But on the question, so I do view that, Senator Austin, as a kind of a separate process from the regulatory oversight process. And I don't know if that's responsive to your exact question.
So both Newtown and Matt, both Newtown and Mystic, both nursing homes in Newtown and Mystic had some significant problems, and there were a number of complaints relative to the clients or the constituents that are there, and ultimately they ended up with citations or violations as a result of what was going on there. But my understanding is that, and I think that we had to do whatever we could to make sure that they were doing the right thing. But my understanding is that they had for a long time been informing regulators that they did not have the appropriate staff to deal with the regulations that they were supposed to be following. Who then is the one responsible to make sure that the clients are getting the correct care? And when they have made that known to everybody, what then is, whose responsibility does it then become?
No, thank you for that clarification, Senator Austin. And I'll begin, and certainly if Mag wants to add, I believe it's certainly the duty and responsibility of the skilled nursing facility to assure for the care and services for the residents that they admit or in their ongoing custodial care. And so there's just no question that ultimately that responsibility falls on the skilled nursing facility. And as Mag pointed out in one of the slides, there is a longstanding federal provision that requires skilled nursing facilities to staff to meet the care needs of their residents. And by the way, we say by and large across the system, Connecticut nursing facilities are meeting that standard and in many cases are above that standard. And we have payroll-based journal reports that are reported to the Centers for Medicare Services and CMS that really can verify that, including the use of licensed direct care staff and nurse aides, or often referred to as CNAs. But the duty is with the nursing facility, and it's the duty of the Department of Public Health and their oversight responsibilities if they believe, based on their investigation or review of complaints, that staffing related issues are violations of both the Public Health Code or CMS standards. That's when you see the beginning of a violation or penalty process moving forward. I would say that many times that's not the conclusion of the Connecticut Department of Public Health, but I think that's where the duties and responsibilities rest.
Right, and when you receive a deficiency, so if this department comes in and says you are not staffing appropriately to the needs of the resident, you're required to provide a plan of correction to the department. Just this is how the process works. Within 3 days, you need, depending on the level of the the severity of the deficiency, you have to provide the Department of Public Health with a plan of correction. They then have to approve that plan of correction and say, that's okay, and then they come out and they inspect to make sure that you've actually implemented that plan of correction, and then they will put you back into compliance. So it's a process, not just of being cited, but also then how are you going to fix it? Okay, that's a good way to fix it. And now we're going to come out and check and make sure you did fix it. And if you can't fix it, then you have to work with the department. And then what are we going to do about the resident care? The last thing that I believe anyone wants to do is to move a resident from their home. So that's always sort of the last resort. But you've seen in the last few years that the department has gone to that extent and has closed 1 or 2 nursing homes in the last few years.
I just want to make sure that we're recognizing that that the staffing shortage is clearly the critical piece in maintaining public health in these facilities. And without that, we are not providing them with the means to be successful with the people that we want them to care for with dignity and respect. And that can't happen unless we make sure that there's enough staff to be hired for all of these positions. So thank you. Thank you very much, Madam Chair.
Thank you for saying that, because it is our biggest issue right now.
Okay.
If I could comment just very briefly, that I think that the surveying and certification activities of the Department of Public Health, at least as they've represented it to the trade associations, see staffing shortages as the nexus of so many of the complaints and issues that they're reviewing. And this is really a new phenomenon that we associate with the public health emergency and the ongoing COVID-19 pandemic. And in our anticipation is as we move forward to the other side of the pandemic, we're expecting to see these issues resolved as staffing resolves. But I think the government itself recognizes that staffing shortages are lurking nearby many of these complaints. So I appreciate your comment very much, Senator Austin.
Thank you, Senator Lesser.
Thank you so much, Madam Chair, and thank you to Mag and Matt for your presentation this morning. I got to give a quick plug. The Aging and Human Services Committee are holding a joint public hearing next Thursday on a bunch of nursing home related bills. We also have additional bills that are not going to be in the joint hearing, and would love to attract whatever attention and interest from members that we could get. But specifically, I had a couple of questions, if I could. One, it's my understanding that a lot of nursing home owners also have related party entities. These are landscaping, pharmacy, culinary businesses that are associated with nursing homes. And just with regard to allowable costs, are there caps on allowable costs for payments to related party entities? Is that something that is reflected in the cost reports?
Yeah, I'll take that, Senator Lesser, and I appreciate your question very much. I do want to be really clear that these annual submissions to the Department of Social Services under this cost reporting structure very clearly require for-profit nursing homes receiving Medicaid dollars to no later than December 31st each year to submit to DSS a profit and loss statement from each related party that receives from the nursing facility $50,000 or more in goods, fees, or services. That is the standard that was adopted by the Connecticut General Assembly several years ago. And yes, the department has the authority, and my belief is they have the ability to enforce this authority, but I'm not aware that any nursing home has been found to have a related party that has submitted excessive costs that would be characterized beyond related as payment to the related party, such that the department would reduce them. Having said that, it's all subject to the cost caps. And I think we could say that by and large, or overall, those costs are not really being recognized in full in the rate setting system. But yes, that's very transparent and reported. And it was the leadership of the Connecticut General Assembly that required that in our system perhaps 7 years ago. Many states are moving in that direction, but Connecticut has had that on the books for a number of years now.
Great, thank you. And my second question is, as we switch to an acuity-based system and we are encouraging nursing homes to prioritize sicker patients, does that impact staffing requirements? I know we heard about your current staffing struggles, but do we need to update staffing requirements to reflect the switch to an acuity-based system? Should we be requiring more RN hours? How do we respond to that?
I think that if I can, Matt, if you don't mind, I'll start with that. We've always relied on the federal standard, which is that you must staff to the nursing needs of your resident, and the judgment of the surveyors when they come in to make sure that that is appropriate. We're looking forward to seeing the CMS study. There aren't any recent studies on the appropriate levels of staffing and combination of staffing. And we speak to this a lot. You know, there's sort of an art to staffing as well as a science, so that you know the type of resident you have and the needs of the resident. And so you know sort of the mixture, how many RNs you need, LPNs, CNAs, you can, you know, what time of day you need more CNAs, what type of day you might need more licensed staff on the floor. And so we like the ability to have a flexible staffing level so that you can flex it throughout the day and be judged sort of on a 24 hours level. You know, what's your staffing numbers and ratios for the entire day. But we're looking forward to seeing what happens on the federal level. We're looking forward to seeing that study, to having discussions with CMS regarding what's the appropriate levels and ratios of the staff for the nursing home. I think the acuity system builds in an incentive to increase your staffing as your higher acuities, because that's what they're paying you for. They're paying you to adjust your direct care staff.
Right, and I wholeheartedly would agree with Mag's characterization of that, but I don't think the sector believes that the acuity-based payment system is going to be wholly responsive to the staffing needs that skilled nursing facilities will have over time, especially on the issue of their ability to accept hospital admissions. There's a really you know, I know we overuse the word crisis, but certainly there are many challenges that are very present today with a nursing home's inability to take an admission, and really, it's really a dysfunctioning or inefficient healthcare system at work here when a person is in a hospital that could step down to a lower level post-acute care environment. And are unable to do so due to staffing issues. So while the acuity-based payment system may have a sensitivity or a dial that will increase their payment because staffing would increase when you're addressing needs of higher acuity residents, it doesn't create the workforce or the the certified nurses assistants or licensed staff that would be needed to really address the inefficiency and shortages that are causing so much concern in the system.
Thank you very much.
Thank you. Representative Gilchrist, did you put your hand up by chance? Okay.
I did not, but thank you for checking in.
Okay, thanks. Representative Nuccio.
Thank you, Madam Chair. So I had a couple of questions. I've talked to a few people regarding the nursing home situation that we're seeing. And with the minimum staffing requirement that we have right now, do you feel like there are nursing homes out there that have more people and not enough staff? Is that something that we think is happening? Or is it the converse and we're saying they have open beds that they're not filling because they don't have staff? Are we at risk? Are we at risk for, like, having more staff and not more people and not enough staff? Or are we losing opportunity because we have more beds and not enough staff?
I can speak to my membership. I have a smaller membership, but I do have several members who have restricted their admissions because they have enough staff and adequate staff to care for the residents they have. but they don't want to stretch that staff too thin. So they have certain standards of staffing. Maybe they're a 5-star, 4-star staffed facility, and they want to remain that way. They don't want to lower their standard of staffing, and so they won't take new admissions, but they have plenty, they have staff for the residents they have. There are other buildings where they're struggling to get the staff in that they need to care for the residents they have. And that's when they turn to pool, or they start to refuse admissions because they just need to make sure that they have the staffing. The numbers show that, when we implemented the 3.0 staffing, minimum staffing, we did not believe this was going to be a problem at all. And now we see it's a struggle, and a particular struggle in rural parts of the state to find CNAs. Struggles we haven't had in 20 years, 30 years, struggling to really find the trained and certified staff to be able to come into a building. People are posting open positions and getting no applications, or they're hiring someone who doesn't show up on the first day of work. I mean, it's their experience. It's very frustrating. It's upsetting. And when we talked before, when Senator Austin talked about the mission that nursing homes have, there are people that are questioning their mission of whether they can actually continue to operate a nursing home in this environment. So we are at a crisis level when it comes to the workforce crisis.
I probably don't need to add anything to Mag's comments, but I would say that nursing homes feel, and it's really a reference to the comment we were making earlier about the federal staffing requirement, is that you must staff to meet the current needs of the resident. Most operators, and I believe the Connecticut Department of Public Health holds this view, that this is a much stronger standard of accountability to Connecticut nursing facilities, that they must in a case-by-case basis be able to represent they have staffing to meet those particular needs of the resident. And that's notwithstanding any minimum staffing requirements, whether it be 3.0 or 3.8 or 4.1 or whatever is being contemplated at the federal level. And so there's a stronger authority in regard to that. And so I think I was saying earlier that nursing homes are held to that standard now. And by the way, I think Mag and I are both well known. We encourage people who don't believe that nursing homes are meeting that standard on a case-by-case basis to complain under the various venues and processes that are available for that at the Connecticut Department of Public Health and the Connecticut Long-Term Care Ombudsman Program.
So, thank you.
Yeah,
I think the issue I hear here, because every call that I'm on, everybody's having a staffing issue, right? It's not just this place, it's literally every place, which I think at some point we have to kind of acknowledge that the work environment has changed, right? These people just didn't disappear from the workforce. Everybody's off doing different things now. We have to adjust our expectation. With that, I've talked to a few people who think that possibly the better solution is to have the nursing homes be like for the absolute total minimum amount of people that need that care, and to really shift the services into the home-based services, which you talked a little bit about, the home community based, and the shift that you've already seen, about 69% of them being home-based now. So I think that at some point we have to kind of sit down and reimagine how we're taking care of the elderly and what we're putting in place, because they're going to force us to do it anyway. And I think there might be some savings or some opportunity in there to provide better care at home so people can age in place. Just something to kind of think about in relation to whether we have people in a institutional care or we're providing services on a home basis. So thank you very much.
all right. Representative, are you finished? Representative Nuccio,
Yes, ma'am.
are you finished? Did you get both your questions in?
Yeah, I think so. I think they've acknowledged that there's a shift to the home base, but I guess are the nursing homes working to try to establish that as a type of care, to shift people to the home base, or are we still trying to kind of get more people into the nursing homes?
I think that's a good question for us to talk about in general, because I think we have to find out. We also need DSS to be part of that, because money follows the person is one of the mechanisms. And I have had experiences with people in my district who have had major problems with specific hospitals, I mean, nursing homes, which have totally negated the process and the patient. So I think this is a good surface discussion, but there's a lot more that meets the eye in the evaluation and the follow-up that we are expecting to have our agencies provide with the nursing homes. So I think this is not the end of this conversation, Representative. I think this is just the beginning.
Yeah, I
can
look forward to those conversations, Madam Chair.
Thank
Can I
you.
just make one comment with
Mhm.
regard to that?
Mhm.
There was earlier this year or last year, the Department of Social Services asked each nursing home to submit a plan for their future. And, we've been working on the right sizing plan for several years. And particularly in the not-for-profit sector, you have many nursing homes that actually are part of a continuum. So my members will provide home and community-based services, they'll provide assisted living. Nursing homes are just a portion of a segment of a sector of what they provide within the full continuum. So we have a good understanding of sort of the rebalancing and understanding the role that home and community-based services play. Nursing homes also have a critical role in the subacute short-term care sector here in the state of Connecticut. So, we've also, the pandemic sort of raised that issue also. So we definitely need the subacute piece. But the former commissioner of social services asked each nursing home to submit by April 1st a plan on what the future will be when it comes to your nursing home, the size of your nursing home. Required everyone to take a look around. What was the demand? What was your census? What's the census of the nursing homes around you within your catchment area? And tell us what you're thinking. So everyone received the plans. There were some people that had elaborate plans, strategic plans, some people who had, did not plan to make any changes. We haven't seen the individual plans, but right now the Department of Social Services probably has for the very first time a real landscape of the nursing homes in the state, what their thoughts are, who they're serving, and what their plans are, at least for the next 1, 2, 3, 4 years. This is something we haven't had in our right sizing initiative in previous years. A lot of people had said, well, we're full, we're not going to think about it. We're full, we're not going to think about it. This was the first time the state said, all right, everybody stop. Take a look around at your competitors, take a look at your market, take a look at where your census has been, and tell us what you think you might do. For my members who are nonprofits, it's a little bit lengthier process to do strategic planning, but it has sparked a lot of strategic planning that maybe had not, during the pandemic, everyone was so immersed in the pandemic, and really taking a look at what is the future of their nursing home on their campus? How many beds do they need? You've already seen several nursing homes have submitted CONs to the department to reduce their beds, 10, 20, but still recognizing what the demand is going to be in the future. So I think this is a good time to start really reinitiating this conversation, because now we're all sort of at a starting point where we've all taken a good look and really are ready to start talking about it.
Right. And with the chair's permission, if I could just comment very briefly, I promise it will be brief. Yeah, because
we have a lot of people who have.
Thank you, Representative. I just don't want to miss the opportunity. If the question might be, are nursing homes resisting right sizing and rebalancing? I wanted to state very clearly, we're not. We I think are considered strong partners, both associations with the right sizing and rebalancing efforts. And we see that we have to have a system that's going to address the care needs of a range, especially as our elderly population is exploding. But we also say that we do need to have a vibrant system of long-term care and skilled nursing facilities as well. We can't just throw one ball up here. We have to throw up both, and we're not resisting right sizing and rebalancing and enhancing home and community-based services.
We all agree with you both on what you're saying, but what we're seeing out there is a little bit different in this retrospect with our constituents. So we're going to continue this conversation, and I'm going to ask you guys to try and make it briefer, because the more we talk, we get more questions, and this is going to let us know that this is not the end of this conversation. So, Representative Johnson.
Thank you so much, Madam Chair, and thank you for your very informative presentation on these issues. First of all, I think I have a question about the certifications that you have with respect to, you've got a nursing facility certification, skilled nursing facility certification, acute care for lower care than it would be actually a hospital level of care, but nevertheless acute care certification. And then we've got an ICF certification that seems to only apply to developmentally disabled people and in a group home type setting. So I'm just wondering, in terms of the certification aspects, I hear from people in my district and other people in the surrounding area that that they can't take a particular person because of the level of care. And I don't know what that means, because it's always been, in my view, when we went from, in 1988, when we went from skilled nursing facility and ICF care on a federal level to just plain nursing facility care. And then we made some of these adjustments later on. I just wondered, how are we making determinations as to what do you mean by level of care? If you could help me out with that.
Sure. I mean, nursing homes are licensed as chronic and convalescent nursing homes by the Department of Public Health, except for there are 10 nursing homes that have what's called the rest home with nursing supervision level of care. That level of care is being eliminated by the department. So everyone's, now held to the standards basically of the chronic and convalescent nursing home. You can take post-acute care patients, you can take long-term care patients with that license, but you need to be able to provide for the needs of the resident that you're taking in. So if you're taking a resident in that has some particular type of is a bariatric patient, and you do not have the physical plant or the staffing to be able to care for that patient, you cannot accept that patient, because you need to be able to meet the needs of the resident. So that may be what people are saying, they can't meet the needs of the resident because they just can't provide that level of care. There are some nursing homes that specialize in post-acute care. That's, a very high level of care. You're coming in for a week, you're coming in for 8, 9, 10 days after a hip replacement or cardiac surgery. That's a particular specialty. And so there are nursing homes that will take that in. There's others that aren't equipped to take in subacute patients because maybe they don't have the trained nursing staff to be able to do that.
Thank you for that. And just to follow up on that, and for my second question, is there a determination being made when a person is, say, in a hospital? Maybe they don't meet the 3-day requirement for Medicare coverage under the skilled nursing facility level of care, but nevertheless, maybe the discharge planning staff is trying to place them someplace, and they don't have a home, so they're homeless people. And they may need a level of care that can't be determined by, can't be accepted by the surrounding nursing facilities. What happens when there's no home to put them in, and the shelter says this is too high, we're not a level of care, but yet the rest home can't take them because the person requires more than a rest home level of care? Are you hearing about this issue? I hear about this all the time in my district.
I think there are gaps in the current continuum. You have to be at nursing home level of care to come into a nursing home. So you have to have certain activities of daily living needs and other, to be deemed appropriate for nursing home level of care. So if you fall in between, and you can't find home and community-based services, you don't have a home. I think that's why, and the state's working on this. They're working on it with residential treatment programs that are now Medicaid certified. There are, if it's a substance abuse issue, they are working on it with the residential care home level, because they're trying to raise that up to be in the home and community-based settings rules, so that someone can be discharged to a RC residential care home and receive waiver services if they need that additional level of care. But there's definitely gaps in our system where someone who does not have a home has and needs a certain level of care. It is definitely a need that we need to find some way to better assist these people in finding the appropriate placement. And sometimes it's not short-term, it's a long-term treatment needs or service needs and shelter. But the nursing home is not always the appropriate place, because they are not at nursing home level of care, and it's not the right setting for someone who doesn't need nursing home care.
I just want to follow up with an example quickly, just to try and explain what I'm saying, just so that we're spot on in what we're talking about. A person with mental health, pretty severe mental health issues, and also a problem with not being able to change the person's diapers, and so they have some type of behavioral health problem. They also have digestive problems, and they're not able to manage their own care. So it's activities of daily living that are not going on here yet. Nobody wants this person, and their person's being refused, and the shelter can't take them. It's too high a real level of care, say for a rest home, because the rest home doesn't take care of activities of daily living like managing the diapers and the behavioral health issues. And so this person is left on the street. And so that's what I'm dealing with here in this district. And back in the day, it seemed like that would be the kind of patient that was a nursing home level of care.
Matt, I don't know if you want to respond. If it's one activity of daily living, then that would not be I'm just trying to be, it's something we need to discuss, I think, and really find the appropriate level of care. Mental health needs for mental health are not what our nursing home is an appropriate setting for, and we actually are discouraged from being a primary residence for someone whose primary diagnosis and need is for mental health services. So we need to find the right place that can provide these services. I think we're moving in that direction by expanding the waiver services and expanding the settings where they can be delivered. It's not going to solve everything, but I think it's a really good direction that we're going in the residential care home and the Department of Mental Health and Addiction Services.
I'd love to follow up with you on that. I won't take anybody's any more time on this, but this is a real serious issue, and we're just leaving people with behavioral health issues that really need some type of long-term care. And I think I don't know if the Medicaid program has changed to the point where they're not addressing this. I know that there is a limitation on how many behavioral health patients you can take now because it changes your certification, but and we can talk about the certification requirements later on, but I'm not sure if those are state or federal, and love to be able to talk some more about this. Thank you so much for your answers. Thank you, Madam Chair.
Thank you, ma'am. Thank you for your questions. And I hope that you, Meg and Matt, you're hearing the seriousness that we are all experiencing out here with our constituents. So I'm sure you hear it too. So next, Robin Comey.
Thank you so much, Madam Chair, and thank you for the overview. I'm new to the Human Services Committee, and this is all very helpful background, Mag and Matthew. I think my questions are pretty quick because I am new and probably just getting caught up on stuff. You mentioned earlier on $21 goes back to the state. I wasn't clear on, is that per patient? Is that per day? Is that I wasn't clear on what that $21 was.
Yeah, thank you, Representative Comey. That is a tax on nursing home utilization. It's assessed on a per day basis, and it is part of a federal revenue maximization program instituted in Connecticut many years ago. That $21 going back to the state revenues can be reinvested, not just in nursing facility care, but in Medicaid finance, home and community-based services. And when those dollars are spent through the appropriations process, that can be eligible for an additional federal match at 50%. And so that provider tax or user fee is under that program.
And
So per patient.
It's per patient per day.
Per patient per day. That's what I was looking at. Okay.
On all patients except for Medicare patients. If you're in there on Medicare on subacute, you don't have to pay the provider tax. The federal government won't let us assess it.
Okay.
And I think it raises about $146 million a year.
Oh, thank you. Thank you. And then quickly also in child care, which is my background, we talk a lot about the true cost of care. And I'm wondering if you can speak to that. Is that something that is baked into your formulas, or as an industry, is that something that you may have just showed us that I just didn't comprehend in that same way that we do in the childcare industry? And if you could just talk about that.
Very, very briefly, I think some of our slides present that because the true cost of care, the actual cost of care is capped and not recognized in the rate system. I think that inherently the rate setting system doesn't recognize the true cost of care. And it's particularly an acute problem for very high Medicaid facilities that aren't able to cost shift over to private pay or Medicare. And so I do think it's an inherent issue in the system.
And have you done that analysis or?
Yes, actually, we did that analysis in a couple sessions ago to show that the true cost of care, that there were so many nursing homes that were just not being paid the true cost of care, particularly when it came to staffing. And that's why the legislature and supported our efforts to try to get a rebase of the rates so that we could really reflect the true cost. So now will be phased in 3 years. We're always behind the 8 ball because these are 2019 costs, right? But then we've also been allowed additional increases to address the staffing increases, staffing cost increases. So, but that is we really appreciate that and the support that we've gotten over the last couple of years to really try to get us closer to the true cost of care.
Okay, thank you so much for that. And I'm finished, Madam Chair. Thank you.
Thank you. Representative Cook.
Thank you, Madam Chairman, and thank you both Meg and Matt. It's great to see you guys, and thanks for the information. So I have numerous questions, and I know Tony's eyes are going to pop up, so I'll only ask 2. So my first question is going to start with the 3.0 minimum direct care staffing ratios and the potential of CMS changes. As you know, this has been an ongoing issue, and 3.0 hours of care literally means that any one of us that can care for ourselves, that would be that you can shower in the morning, brush your teeth, go to the bathroom a couple of times, and there's your 3 hours. And these folks have to rely on somebody else to give that care. And because we have one CNA taking care of sometimes 24 to 40 patients in a day, how is that possible? And do you have an idea of where that 3 hour might be looking to go to? First question.
You mean at the CMS level?
Yes, Meg.
We're anticipating it's probably going to be around 4.0, but we don't know. There are currently, because of the workforce crisis, I think there's some real discussions going on as to what it can be and what it should be. But we're waiting like everyone else to see what the study is going to show.
And then my second question would be, and I have many that I'll ask questions offline to you on that. My second question would be on the wages for CNAs across the board. As you know, and you mentioned it, that we had tried to increase those wages a couple of times. One nursing home owner in the state withheld those wages for about 6 months before they ever gave them to the direct care staff that they were required to. But then the staff was never given compensation back for the delay in those payments. Could you tell me where we are now for CNA staff in the nursing homes across the state, as an kind of an average on what we're being paid, what they're being paid? Because I think that is really one of the crux of our issue with wages versus staffing. When you could go to Target and make $22 or $23 an hour, and we're only paying our CNAs bare minimum.
Sure, I think there's a difference between, there is a variation between a CNA that's been at work for several years, the retention, and a CNA, the starting wage of a CNA. We do a compensation analysis. I can get back to you with some of that information. I don't have it at the right in front of me, and I apologize, but I can get you some more in-depth information on that. I can tell you it's increased significantly over the last several years.
But I do think Representative Cook is spot on correct that we have to be consistently, perhaps annually, boosting the wages of our CNAs, LPNs, RNs, and that we need to separate out these workers from the rest of the, call it the workforce economy in Connecticut. And if we don't begin paying these workers considerably more and considerably boosting their pay on an annual basis, we're going to lose the competitive battle to the box stores and other parts of the economy. So we're very supportive of working on these policy initiatives to assure that this, I'll say it a different way, we won't have enough workers in our healthcare system, let alone our nursing home system, if this workforce isn't invested in. And so whether it's getting to $25 an hour in some short period of time, we just need to put a lot of focus and attention onto this workforce development issue. So I 100% agree with Representative Cook.
And one of the other things that Matt and I always talk about is, you know, it's not just, people aren't going to come and become a CNA because of the starting wage. They're going to become a CNA, an RN, an LPN, a social worker in a nursing home because this is the type of work that they're drawn to. They need to have a mission to work with older adults. And so we need to work on that also, and cultivating, even as young as the elementary school, people that have sort of an affinity for working with this population, and make them understand that this can be a career that they can advance in. And so there's so many different things we need to do to encourage people to come into the field. And this is wages and investment in them is a key piece, but there's other pieces we need to do too, because we need to draw in that special person that really wants to work with older adults.
And I agree with you, but I think that we've literally, and to Matt's point, I would have to disagree respectfully that we've lost the battle. I mean, I have people that leave constantly my nursing homes because of the way that they're treated, the demand that they're put on because their administration doesn't care about them. They're overworked, they're underpaid. And it is not the fact that we haven't tried to do that. It's the fact that they've been taken full advantage of. And so we should not be having to continue to have this ongoing conversation about wages, recognizing that if I can go deal with customers and clothing in a Target or at a Taco Bell, why would I risk injury per se at a nursing home when I have no supports from my administration or the owners? So I think it is a battle that we're well behind as a state. And the only people that are paying for that are our residents in these nursing homes that are being neglected in a terrible, terrible way. So I really do welcome this continuous conversation. And thank you, Representative Walker.
Sorry. Thank you. Thank you very much. Next, Representative DiCaprio.
Thank you, Madam Chair. My question, I'm new here, so I'm trying to learn my way around. I had a brother that was a long-term patient and actually passed away in that Connecticut nursing home. And my question was, I had a couple of questions. One was the possible solution to staffing. I think we've touched on that already, but is there, right now, what is the capacity for taking long-term patients, into the nursing home system in Connecticut? Is there like a main listing, that maybe a hospital or other healthcare providers would have access to? Or do they have to call around to individual nursing homes, or how does that, can someone share how that works?
By and large, the relationship that is most common is one where there's a discharge from a hospital after an acute care stay to a posting care environment, whether that be a nursing home or to a home, back to home, or with home and community-based services and support. So yes, the hospital discharge planners are fully apprised of all of the nursing facilities in their area or catchment area, and including sort of what do we refer to them as, preferred services populations or preferred services providers that hospitals have. And so if it's from the move from the hospital to the nursing facility, it's really that well-developed discharge planning process that where would you intervene. It's very rare that that a nursing home resident comes directly from the community. In the event that would be the desired entryway into a skilled nursing facility, I'm not aware of a statewide sort of entity where you could intervene at. Perhaps Mag is more familiar with that, but we do often hear that it's calling facility by facility seeking admission in those situations.
Yeah, and Matt and I's website, you can find the list of our members. We tell people, we often advise people, even when they're being discharged from a hospital, don't just go to the first nursing home that's recommended. Find the one that's easiest to access for you. Go visit, talk to the residents, talk to the families, talk to the staff, see if it's the culture that you want to be living in, particularly if you're looking for a long-term stay. You want to make sure that this is a place you're going to be comfortable living in. This is going to be your home. But it is word of mouth. It is just, you can go to our site, you can go to the Department of Public Health, we'll have a listing of all the licensed nursing homes. Nursing homes are all licensed on the same level, but very often people want something close to where their loved ones are so that visitation can occur on a frequent basis. But you want to make sure that you have choice. You might feel pressured to be discharged to a particular nursing home because they have an available bed, but you can push back and you can say you want to wait. Also, if you think there's going to be a long-term placement in the future, you may want to put your name on the waiting list of the nursing home that you want to be placed in. Because there is a waiting list law here in Connecticut, and if there's a list, you can stay on it for as long as you want. You won't lose your spot. They'll call you, they'll say, you want to stay on the list? You can say, yes, I do. You'll stay where you are, and they'll just go to the next person on the list. So I think, you need to think a little bit in advance as to where you might want to go if it's a long-term placement.
Well, thank you both for that. And I would be interested in the CNA compensation schedule if you have that available at some point. So thank you very much.
Representative Garabay. I just want everybody to know that we are scheduled for ending at 11, but I think if the speakers would indulge us, I think we could get everybody done within by 11:05 or something like that, so that we can make sure everybody's question gets asked. Go ahead.
Okay, thank you, Madam Chair. So I believe in choices for our seniors. I believe there's a place for long-term care, short-term care, nursing homes, aging in place, our adult day centers, which help to do that. But I also believe that we are in a catastrophic crisis, not just a crisis, catastrophic. I hear about people not getting their meds at the appropriate times. They can go a whole day. I hear about people left in diapers for 8 hours or more, fed their food, going without showers for days and weeks at a time. I have reports, and I haven't been able to confirm this, about nursing homes receiving ARPA funds and none of it going down to the employees to help staff more. And I believe that some of our people, that the care is so poor that they are dying because of that poor care. I know other industries are doing their own trainings, certifications, looking for ways to attract employees, paying more. I understand that there is an employment crisis across the board. But what are they doing, and what do you think about the bill that will up it to 4 hours of direct care, which, as Rep. Cook said, doesn't give you very much in the 3 that you have?
Well, I appreciate your candor and your question very much, Representative Garabay. I would say that, and the situations that you just described, I do not believe are widespread across the entire sector. I believe that there are thousands and thousands of interactions going on between nursing home staff, the operators, and their residents, and it is going well, and the care is of the quality that we would all expect. However, I absolutely believe that we are in a crisis in terms of the stress and the trauma that has been experienced in the system, due largely to the public health emergency. And on the other side, as we're looking to the other side of the public health emergency, the very severe staffing shortages that we're talking about, and the extraordinary increased costs, whether it be the ravaging inflation in the system or whether it be staffing costs.
Mhm.
And so I see that as the nexus of so many of the issues that you describe. But I would not hold to the view that that is the care experience across Connecticut. Now, as it relates to a minimum staffing level of 4.1, I believe that is an artificial a number that can't be achieved in the current environment. As they're reviewing that matter at the federal level, there's been 200,000 nursing home job losses across the country, and Connecticut is similarly experiencing these job losses. And they're not coming back. We're the slowest to recover in terms of these nursing home job losses. So we could adopt a standard that would be that high And it just might not be reflective of the reality of being able to hire those kinds of positions. So I would be very concerned about a number like that. Representative,
So we're going to agree to disagree. I received videos of person crying in pain. I received photos of bed sores that are so humongous, and that may not be the proper term, but it's the one I know, the bed sores. And that person is sat in a wheelchair outside the room in the hall for 8 hours a day without moving her. And she does not have full strength ability to move herself. This isn't just my district or here or there. It is coming in from all over. Someone who's not supposed to be in an infectious situation, and pictures on the floor of the IV with the needle laying on the floor amongst the dust. These are true. Some nursing homes refusing to put cameras, even though that is the law. So for me, it is about the people that by the time we get our act together, that are dying. And I'm serious. Indirectly because of the care they get. And I know that is multifaceted. I know we don't have enough people, but that was way before COVID. COVID just shined a light on what was going on. And, you know, I have these cases, I can share photos, you know, when I receive them, people write to me of their experiences. It's very scary. And I just think that we have to address this sooner than later. We cannot lose one more life. Our seniors deserve respect. They shouldn't have to be punching that call button for 3 hours to be assisted to the bathroom, because they can go, but they just can't, they need help. And they soil themselves. It's not change. It's the human dignity. And I know we're all on the same page. I just see this as super urgent. I do believe, I know a couple of cases who have passed, they end up in the hospital with infections, the acute care. And the people I know, when they are released, the hospital sends out an email to the nursing homes, and it's whoever will take you. And sometimes you don't have a choice. And do you stay in the hospital? I mean, I don't even know if they would allow you to stay on if you're ready to be released. And so you're sent to whichever one says, I have a bed. And then I want to know, do they have the staffing to take that person?
Representative Garibay, I think we all got, we're all there. So I, again, emphasize.
I'll stop now, but
thank you. Thank you.
No, thank you.
Senator Marks.
Thank you so much for the opportunity. So this is near and dear to me. I am a visiting nurse, and for the last 20 years, I've been in home care. So I work for the VNA, which is very regulated under CMS, but I work side by side with the homemakers and companions and PCAs that are out in the home being funded by our Home Care for Elders program being managed by CCCI. There is no oversight. I know you said in your presentation that we're going to start having quality controls for the home care industry, yet none of these industries are regulated. They don't have to have a license. They don't supervise the people going into their homes. We definitely had a death 2 weeks ago of a constituent here in New London. That she died. She had 24/7 care, and she got out of her bed alone and fell and was found by a friend, you know, day or 2 days later, who knows how long, with no 24/7 caregiver in sight and DSS not being called. And we just happened to know about her because the friend has a friend who's a senator, and the senator has a friend who's a state's attorney, and then you start an investigation. So how can we actually do quality control on this industry when there is absolutely no oversight, which I know we can't. And so I'm not even sure how you can answer that. And then my second question is, I know before COVID, many of the women that I talked to who were nurses' aides in the nursing homes said that they would only get 20 hours a week because the nursing homes didn't want to have to pay benefits for them. So they would have to work 20 hours at one nursing home and then 20 hours at a nursing home, or they were only given per diem positions, which we all know with the shortage every nursing home should be able to give every nurse's aide a 40-hour-a-week position with good benefits.
Senator
So
Marks, can we get to the question, please? Because
that is my question. What is the practice now for nursing homes when it comes to hiring CNAs with either part-time, per diem, or full-time?
So I think it's hard for us to comment on a particular home. Every home has their own human resources policies and procedures. We're hearing more. We know that there are some nursing homes that will have really adjusted their work schedule to meet the needs of their CNAs and RNs. Some will, and even the younger CNAs who are still in school, providing different hours, have part-time, half shifts in the evening that fit better into their schedule. We are hearing actually more people concerned because as the wages increase, the CNAs have to cut back their hours so they don't hit the benefits cliff. And that's a real concern to us too, because, they could be working more hours and making more money, but it makes sense for their needs not to, so they can still maintain their childcare or other benefits they're receiving. So, but it's up to each individual nursing home to determine that. And I believe, as employers, we need to modify our employment practices and policies and the culture of the building to retain employees. It's not just a matter of hiring employees, you need to retain them. So there's a lot of work going into, really working on the culture of the building and accommodating a new type of workforce. This new generation of workforce that we need to really adjust our work policies and procedures for. It's just a different type of workforce as we have a younger generation. It's not just nursing homes, it's, throughout the entire country. So I can't really answer what the uniform and universal practices are. I apologize.
And how are you going to do, quality outcomes with home care agencies that aren't even licensed or regulated?
We're not doing the quality measures. That's the Department of Social Services. And we can get you the information of what they're doing for quality measures. And it really has to do with the people that are, the providers that are in the Connecticut Home Care Program for Elders. You're right. It has to do with certain type of training they're doing with their staff. It's more of an initiative right now for things that they're doing as opposed to the outcomes.
But I do think Governor Lamont's budget doesn't part recognize that problem, and he's devoting additional resources to, or recommending additional resources for the oversight in the home and community-based services system that Senator Marks identifies. I believe there's a recommendation concerning additional ombudsman positions there. So I don't think that fully addresses the issue, but it certainly is an acknowledgement that Governor Lamont recognizes that as we shift more and more people into home and community-based environments, we have to have a regulatory oversight system that accompanies that shift.
They're also developing a backup system.
We got to keep moving on. Come on. Thank you. Representative Gonzalez.
Thank you, Madam Chair, and good morning, and thank you for all that information. I agree with Representative Cook that some of the problems is not the wages. It's about the way they've been treating the staff. And I got a question after this. And also I agree with Representative Garvey that the services that the patients are receiving, they're terrible. I also got pictures and phone calls. So I don't agree that they don't have enough staff because they have to raise the wages. Now, my question is, if they are limiting the admission, but they are getting enough support from the state, and if they don't have enough staff, if they are planning to hire and train these people, because meanwhile, it's our people in our community, really they are paying for this because they are looking at, for a nursing home and they can get it. And I think that if the nursing homes are getting enough funding, what they are doing with that money, and when they are planning to hire people and train these people.
Thank you, Representative Gonzalez. I'll say very quickly, nursing homes are not getting paid when they refuse an admission. They're only getting paid on a per diem basis from the Department of Social Services when they take an admission. And so I believe they very much want to take an admission, but they're not getting paid at all when they don't take an admission, not under Medicaid or Medicare.
And as far as the auditing that's going on, we're hoping that we're going to get those answers from the Department of Social Services when they come before us, because we do have a lot of bills pertaining to the maintenance and the auditing of nursing homes coming before us, and the Department of Public Health will also be part of that conversation. Representative Gonzalez, do you have another question?
My question is if they are planning to hire more staff.
They're going to have to if they don't have staff.
And I just want to clarify, the 3.0 is the minimum staffing level. It's not the target staffing level. So you have to have staff at least 3.0. People are trying their hardest to staff at the level that they're used to staffing. Many people staff at, much higher levels than 3.0 because of the particular residents they care for. But it's just I can only speak for my members, and they are trying their hardest to hire qualified employees and then trying their hardest to retain those employees. And as we talked about before, that's all about the culture of your building and how you treat your employees. So there's a lot of effort going into that. We have a long, there are CNAs that have been CNAs for years and years and years in the same building because of the work that they do and the cult and the way they're treated. One nursing home, we don't tolerate bad quality regarding residents or employees. And so we don't want to be sitting here and have you think that we're just taking this information and saying, well, that's how it is, because that's not how it is. And people need to use the Department of Public Health, the laws that we have in place to register complaints, to ask the questions, to come into a building before you're going to place your loved one and ask the questions about what is your staffing level. We have to post our staffing levels. We have to post them every day. We have to update them as people call out. There will be blips in any nursing home, the highest quality nursing home. I have a nursing home member who one weekend just said the entire staff got the flu for the weekend shift, and they were just struggling to find temporary staff to come in. I mean, these blips are going to happen. You can't move residents out. And people work together to try to resolve that and help each other out. But for a sustained day-to-day basis, people should, we can't tolerate people who are not trying to hire the staff. We have to raise the standard and the quality in the nursing homes.
Thank you.
Thank you. Thank you.
Thank you. Representative Belinsky.
Thank you, Madam Chair. This has been an interesting and very revealing conversation, and I just wanted to a shout out to Meg and to Matt for what they're doing. I completely agree that we must raise the standards of our long-term care facilities. But I want to just make an observation. I don't have a question, Madam Chair. The observation is, regardless of who's spoken so far, we're all in search of solutions. And, I appreciate Senator Austin starting the conversation off by talking about the very, very, very concerning issues at Newtown Rehabilitation, which is in my hometown. And I also appreciate, everything that Chairman Garibay from Aging said, and the courage for her to agree to disagree about, the standard of care. There's no question that, there are oopses in the system, and we certainly don't hear about the instances where wonderful care is being administered and there's no problem. We only hear about the problems. One of the things that I also agree with that was said a couple minutes ago, oversight is huge and important, and we don't do nearly enough in the oversight. And that's not a criticism of anybody that's, in this presentation, but, all of us need to take a good hard look at, at the people that are, that are the lifeguards for the long-term care facilities. Our long-term care ombudsman program, they're running around the state with a couple of people, and you know what, their capes cannot carry them fast enough to go from issue to issue, even though the issues are more isolated, than a lot of folks might let us, think. We need to make a commitment to the oversight, and we need to really make a commitment, in my opinion, to our ombudsman program, and we need to make it more robust.
Representative Belinsky, do you have a question?
I do not. I do
Okay,
not.
well then, I appreciate your candor in some of the things, but we're over time, and so I'm trying to get questions answered right now, as opposed, I'm sorry.
Thank you,
Okay?
ma'am.
Thank you, ma'am. Thank you, sir. Representative McCarty. You're muted, Representative. Representative McCarty is still muted. No? Okay. Well, I'm gonna thank Matt and Meg for giving us this time and helping to try and listen to what we are concerned about. But I think one of the other issues that we didn't get into is and this is with DSS, is a process of how people get into the nursing homes. That's critical. And as you pointed out in your slide, it's a much longer, arduous task than probably needs to be. And we need to address that. Representative McCarty, you back? No, you're not. We can't hear you. No, can't hear you. Okay. You can send it to Sue and she'll get you an answer on your question. I apologize for your technical problems. But I have the stories just like everybody else had when we talked about this in the beginning. And so I really hope that we can get honest questions answered that hit the issues that you heard today. We need to find out why there have not been enough audits over the last 2 years, and where are those audits that were done. DPH was supposed to have done a large number of audits, but they did not because they did not have the staff from what we were told. There is a need for more ombudsmen to help in evaluating and following up with our nursing homes. They were all over, as Representative Belinsky pointed out, and Representative Cook. They're all over the place. And we also need to get a plan from the nursing homes, because yes, we're going to help get the people, but it's also part of their job too to get the people. So they need to tell us what are they doing to help get workers in their sites and getting them addressed to make sure that we do have a very bare minimum of 3. We should be at 4 or 5 on the staffing. So I thank you for staying late. I thank you for staying over your time. And I look forward to continuing this conversation as we go forward to the public hearings that we will be having starting next week. And we look forward to that. And I was trying to find the date that we would be doing public health and DSS, public health and DDS are on Tuesday, February 21st. And then Department of Social Services will be on February 22nd. So I thank you, everybody, for this time, and everybody have a great day. Thank you.
Thank you very
for the
much.
opportunity.
Thank
Thank you.
Thank you.